Good evening, and welcome to tonight's webinar, Post-COVID Care Help for the Long Haulers. My name is Christina Davis, and I'm the Nurse Navigator for the RWJBarnabas Health Post-COVID Care Program. It is my pleasure to moderate this important discussion. While some patients recover from their COVID-19 infection completely, there are some that are still suffering from the after effects of this virus. Our goal is to get you back into your communities, back to your families, back to the activities that you love, but more importantly, back to your usual state of health. As our state continues to reopen, it is imperative that we return to our communities in the safest way possible. Tonight, we have compiled a panel of experts specializing in the major areas where individuals are experiencing continuing lingering symptoms from COVID-19. Joining me on our distinguished panel are Dr. Vanessa Trespalacios, Internal Medicine Specialist and Medical Director of the Post-COVID Care Program, Dr. Jeffrey Lander, Co-Director, Sports Cardiology, Sports Medicine Cardiologist at RWJBarnabas Health, Dr. Pooja Raju, Pulmonologist and Sleep Medicine Specialist, RWJBarnabas Health Medical Group, and Dr. Nalia Schreiber, Psychiatrist, RWJBarnabas Health Medical Group. I would like to start, thank you for everyone for joining us tonight, but I would like to start and introduce Dr. Trespalacios. Dr. Trespalacios is a board-certified internist at RWJBarnabas Health Medical Group, where she heads a busy premier primary care practice. As program architect and medical director for the post-COVID care program, Dr. Trespalacios developed a multidisciplinary clinical model for managing the long-term health effects of COVID-19 illness and has worked alongside others in leadership to implement this care model throughout the RWJBarnabas Health system. During the height of the pandemic, she was one of the key members on the team that piloted the COVID-19 transitional care program at St. Barnabas Medical Center, which has now become a system-wide program. Previously, she served as Medical Director of Population Health for Essex County and is currently on the Executive Board of Trustees for the United Way of New Jersey. Welcome, Dr. Trespalacios.
Thank you, Christina. Thank you for the introduction and thank you for moderating tonight's discussion. I'll start off with talking a little bit about what is a long hauler. So COVID-19 is the illness caused by the SARS-CoV-2 virus. But for simplicity, I will refer to both the illness and the virus as COVID. These are patients who have, in theory, recovered from the worst impacts of COVID and have tested negative. However, they still have symptoms. The NIH definition of a long hauler is people who have symptoms that develop during or after an infection consistent with COVID, continue for more than 12 weeks, and are not explained by an alternative diagnosis. It usually presents with clusters of symptoms, often overlapping, which can fluctuate and change over time and can affect any system in the body. While it's still being defined, the INH is referring to this condition as PASC, or post-acute sequelae of COVID. Many of these patients have been dismissed by medical professionals, but I assure you that this is very real and quite extensive. This condition can affect anyone, old and young, otherwise healthy people, and those battling other conditions. It has been seen in those who were hospitalized with COVID and patients that were never hospitalized and even had very mild symptoms. The latest data has found that about 10% of all patients diagnosed with COVID will become long haulers. While 10% might not sound like a lot, given the number of people who have been or will be infected with COVID, the public health impact is going to be profound. As of today, there have been nearly 30 million cases of COVID in the US, with about 56,000 more reported each day. So if you do the math there, 10% of 30 million is 3 million. We are potentially on the brink of a public health crisis. What we have found in these patients is that there is no relationship between the severity of the disease and the likelihood of becoming a long hauler. In other words, even patients who experience mild acute disease can become long haulers. For some people, the symptoms are nothing like the original symptoms when they were first infected with COVID. Symptoms often fluctuate. Patients describe good days and bad days. There is a mismatch in objective versus subjective What a patient is feeling often does not correlate with test results. Symptoms are of varying degrees and can range from mild to incapacitating. And remember, this condition can affect anyone. There seem to be some risk factors to becoming a long hauler. Age, particularly those over the age of 50, excess weight, asthma, and reporting more than 5 symptoms in the first week of your acute COVID infection. One of the common questions is what are the most common symptoms? And the list is actually really long, wide, and inconsistent. I can tell you that the most common symptom is shortness of breath, followed closely by cough, fatigue, chest pain, and palpitations. A lot of patients describe difficulty with thinking and concentration, which has been referred to as brain fog. There are a lot of patients that describe anosmia, which is loss of smell, or dysgeusia, which is loss of taste. And I know that a lot of people have found that this is what they call a telltale sign, but it's only one of the symptoms. Joint and muscle pains, headache, intermittent fevers, and GI symptoms as well. And of course, there's a lot of anxiety and depression surrounding this. Some of the more obscure or stranger symptoms that I have heard of are, for example, a patient with olfactory hallucinations, meaning she thought there was something, she smelled something that wasn't really there. Another patient had something like a post-concussive syndrome. She had a lot of light and sound sensitivity and therefore could no longer drive or ride in a car with her eyes open. The cause is the next big topic at hand, and some theories suggest that prolonged symptoms arise when a patient's immune system never resets from high alert during the original infection, in effect turning into an autoimmune response that attacks the body and targets shreds of our own cells that were destroyed by the virus during the acute illness. This is similar to myalgic encephalomyelitis, also known as chronic fatigue syndrome, which is believed to be another post-viral condition. Other situations that might cause new and ongoing symptoms include the virus being present for a longer time than usual due to an ineffective immune response, reinfection, for example, with another strain of the virus, or damage caused by inflammation and a stronger than usual immune response to the infection. COVID-19 continues to evolve, and while we clearly don't have all the answers, there is help. Here at RWJBarnabas, we have developed a structured, integrated, multidisciplinary program for long haulers. And if you'd like more information, you can go to our website at www.rwjbh.org/COVID-care. Or you can reach out to us at 1-888-COVID-94.
Dr. Trespalacios, we did receive a few questions from our audience ahead of time. One of them is, are long haulers still contagious?
Dr. T is what a lot of my patients call me, for those of you that don't know, because the name is long and there's a lot of letters and vowels all together. So Dr. T is fine. No, long haulers are not contagious. Long haulers are no longer contagious. They follow the same rule as anybody else that has been infected. The original symptoms, you quarantine for your 2 weeks or your acute symptoms, and after that, you're not considered infectious.
What are some of the more unusual symptoms that you've seen or discovered with the patients coming into the program?
So like I said before, those were a couple there. There was also one gentleman who had severe gum pain, and he was losing weight because he had too much pain when he was chewing from the gum pain. We have seen some patients, I personally haven't, but some of my colleagues in the program have seen patients that have actually lost teeth, teeth falling out.
A question that's on everyone's minds: should long haulers receive the COVID-19 vaccine?
Absolutely. Everyone should receive the COVID-19 vaccine. It's the way that we're going to move beyond this pandemic as a nation and worldwide, really. But yes, everybody should get there's no reason that long haulers should not get the COVID vaccine.
Can you get past post-acute sequelae of COVID from the vaccine?
No, you cannot get past from the vaccine.
Okay, and the last question I have for you is, have any patients experienced elevated blood sugars or elevated A1Cs as a result of having COVID?
Yes, we have seen some patients that whatever disease they had prior, whatever condition, such as diabetes, for example, has become harder to control. We've also seen some patients develop new high blood pressure or trouble with elevated blood sugar. So it seems to be a new condition for them. We don't know if it's going to be long-lived. Again, we don't have all the answers just yet. But yes, we have seen that. And you should be working with your endocrinologist on trying to get those numbers under better control.
Thank you, Dr. Trespalacios, for your time tonight. I would like to now introduce Dr. Raju. Dr. Raju is board certified in internal medicine, pulmonology, critical care, and sleep medicine. She's the Associate Director of the Adult Pulmonary Cystic Fibrosis Center at St. Barnabas Medical Center and the Medical Director of Sleep Medicine at Claramas. Welcome, Dr. Raju.
Thank you, Christina, for the introduction. Good evening, everyone. It is an honor to be here this evening to discuss with you post-COVID care in those that have long COVID syndrome. So we are all aware of the devastating acute effects of COVID-19. However, it's also known that there are tremendous residual and ongoing effects. According to some data from the WHO, about 25% of patients will have symptoms for at least a month. And then some are still unwell even at 12 weeks. These symptoms themselves can be very debilitating and cause a great deal of frustration for those that are experiencing the symptoms. And then, as Dr. Trespalacios had mentioned, that it's important to recognize that not only do those that have severe disease end up with prolonged symptoms, but even those that have mild disease may develop symptoms that last for long periods of time.
In your experience with post-COVID patients, what are the most common symptoms patients have?
So pulmonary-wise, common symptoms that we see are cough. Cough can be a dry cough. It could be a postnasal drip, a tickle in their throat. It could be even a productive cough where they're bringing up a lot of phlegm. We see some people that have wheezing, which is sort of a whistle in their chest. They may have ongoing chest discomfort, which may cause difficulty for them to have or difficulty for them to take a deep breath. And then most commonly we see shortness of breath. And this shortness of breath can really occur with activity. It could occur at rest. So majority of the pulmonary symptoms are these.
Okay, so what about sleep? Have people been complaining of sleep difficulties?
So they have, much less often than the pulmonary symptoms that I've seen. I've had patients complain of excessive daytime sleepiness. We've tested them for it and confirmed that they do have daytime sleepiness. A lot of people will have insomnia, nightmares. So they definitely do end up with sleep difficulties.
What are some of the post-hospitalization issues you can help people cope with or deal with?
So we've been seeing a lot of people that are hospitalized, and when they are discharged, a lot of them do get discharged with oxygen. This oxygen they may need to use at rest, may need to use it on exertion. Some may need to use it just at night. But a lot of times, majority of the time, we're able to gradually decrease their need for oxygen and ultimately get them off of the oxygen. Another pulmonary issue that we see with patients who are hospitalized is that they have the predisposition to develop blood clots in their lungs. So they end up being discharged on blood thinners, and these people also need to be monitored closely for side effects and excessive bleeding. So those are some of the post-hospitalization pulmonary issues.
What do you think drives these underlying symptoms to come about?
So as Dr. T had sort of alluded to, that we don't necessarily completely understand what drives or causes these symptoms. There is a lot of research going on to help us understand more, but at this time, we do believe that there may be residual inflammation in the airways or the lungs itself. Some people may develop scarring of their lungs from severe disease. We see this a lot in people who are discharged from the hospital. And then blood clots can also contribute to shortness of breath. And symptoms may not necessarily be directly related to the lungs themselves. They may have associated heart effects that can manifest as shortness of breath. So that may also contribute to their breathing difficulties. And then what I've found is that regardless of the severity of their symptoms, a lot of people will have overall deconditioning, muscle weakness, fatigue, and concomitant anxiety as well.
So what is your role as a pulmonologist in the workup and treatment of these patients, and what would you advise to your patients in general?
So basically, when we see somebody post-COVID, we would really do a thorough history to assess, when their symptoms came about, what symptoms did they start with, what symptoms do they have residual, do they have any past medical history, such as chronic lung problems. We would then do a physical exam and then really look into what further testing and treatment they would need to help in their recovery from COVID. And then testing itself can range from, pulmonary function testing to assess their lung capacities, and we could also do walk testing to check their oxygen levels when they walk, to make sure that people who are not on oxygen are not going to require the oxygen. And then we do commonly get x-rays or CAT scans to really look at the lung tissue itself. And then when you look into treatment of these patients, obviously not all patients are the same. Their treatments are very highly individualized, depending on what we think may be causing their underlying symptoms. And then when we do treat them, treatment could include inhalers, sometimes steroids, oxygen if needed, referrals to other specialties like cardiology, and then obviously important is pulmonary rehab, breathing exercises, and then any devices that may help them with their breathing capacities that they could do on their own.
Is there anything else that you would recommend for people to do at home to help them breathe better in general, including some of the stuff that you just mentioned?
So, anything done should be done in discussion in general with your treating physician to make sure that it's safe to do any exercises. But common things that I would say would help would be to be as active as tolerated, sort of increase your day-to-day activity, slowly, but to be active. Deep breathing exercises also help keep your airways and your lungs open. Getting enough sleep allows your body to heal, and then using the prescribed therapies.
Great. Thank you so much, Dr. Raju, for joining us tonight. We really appreciate it. Next, I have Dr. Lander. Dr. Lander holds multiple board certifications, including cardiovascular medicine, vascular interpretation, among many others. He's authored the American College of Cardiology's pre-participation cardiovascular screening for adolescent and young adult athletes modules, published several articles, as well as presented multiple research papers on a national level. Dr. Lander frequently lectures and is actively involved in teaching, has been a speaker for the American Heart Association, the American College of Cardiology. He is a team cardiologist for Seton Hall University and is the incoming president of the New Jersey chapter of the American College of Cardiology. Welcome, Dr. Lander.
Thank you, Christina. Some of the most common questions I've gotten during the pandemic from patients, from friends, family members are in regards to COVID and the heart. Now, early on in the pandemic, we learned that compared to the general population, people with underlying cardiovascular disease are significantly more likely to contract severe forms of COVID-19. And now, even though the death rate from COVID has dropped, cardiovascular disease remains a major predictor of poor outcome from COVID-19. And there are a few ways in which cardiovascular disease increases the risk of severe COVID-19. It can be challenging enough for a healthy heart to deal with the stress of COVID-19. But if someone has pre-existing heart conditions, such as blocked heart arteries or weakened heart muscle, it may make it more difficult to survive the stress of COVID. And during the infection, the body may have to deal with issues such as low oxygen levels, low blood pressure, and clotting problems, all of which really pose risks to the heart. In addition, oftentimes people with cardiovascular disease have poor metabolic health. This is often caused by diabetes and obesity. And these in and of themselves can cause inflammation and increase the risk of blood clots, which may exacerbate the effects of COVID and increase the risk for significant complications. And not only does cardiovascular disease increase the risk of serious COVID-19 illness, but on the flip side, COVID can cause heart damage. It can do this several ways. One way is the virus can directly injure the heart. Another way is via excess inflammation. The body's natural response to infection is inflammation, but sometimes the body's response is too much. In particular, the body releases inflammatory molecules called cytokines. They can be helpful, but if there's too much of them, it can cause something called a cytokine storm and negatively affect organs, including the heart. Now, also, COVID may disrupt the balance of oxygen supply and demand in the heart, which can injure the heart. It can do this a couple of ways. For example, fever and infection increase heart rate, making the heart work harder during the COVID illness and require more oxygen. Low blood pressure seen during COVID can put further stress on the heart. And during COVID, the body's more prone to developing clots. And if a clot is formed in one of the arteries of the heart, it can deprive the heart muscle of oxygen, causing a heart attack. We talked about a lot of bad stuff there, but it's not all doom and gloom. If we optimize our cardiovascular health, it may not only decrease the risk of complications from cardiac disease, but it can mitigate any vulnerability if a person is exposed to COVID. If you do have underlying cardiac issues, it's important to continue to manage them along with your doctor. I certainly know that some people have been hesitant to visit their doctors during the pandemic, but it's extremely important to continue to care for your heart and your health. I can assure you, your doctors at RWJBarnabas Health have taken the utmost precautions to keep you safe during the pandemic. Of course, we always want to remember the basics to stay safe. Wear a mask, wash your hands, distance when possible, and as Dr. Trespalacios mentioned, get the vaccine when it's available to you. A significant percentage of people who have been infected with COVID may develop longer-term symptoms, and we can see this in up to a good 10% of people who are infected. And just like Dr. Trespalacios mentioned, it can happen to anyone. It can happen if you're young, if you're old, if you have underlying issues that you're battling, or if you're otherwise healthy. And it could happen if you had a mild case or if you had a severe case and were in the hospital. So it really can affect anybody. And some of the long haul cardiac symptoms we encounter are chest pain, shortness of breath, an elevated heart rate, and fatigue. If you're experiencing some or all of these symptoms, I always think it's better to err on the side of caution and speak with your doctor. Generally not a good idea to try and tough it out, so to speak. And depending upon what symptoms you have, how severe they are, if you have other underlying medical issues, your doctor may want you to visit with a cardiologist who deals with the complications of what we call long haul COVID. And if your doctor does want you to see a cardiologist, when you come in for your visit, you'll talk to the cardiologist, you'll do a physical exam, we'll do an EKG, and if you haven't already had blood work, you likely will require some. Oftentimes we'll do an echocardiogram, which is an ultrasound of the heart, to check the structure of the heart and assess if there's any decline in heart function. You may have to wear a monitor so we can assess heart rhythm. And oftentimes we'll do a stress test. The stress test involves walking or jogging on a treadmill while connected to an EKG. And this really gives us a sense of how much activity you can do and alerts us to any rhythm problems or blood flow problems when the heart is stressed. Sometimes, less commonly, we may require additional information and go on to do more advanced testing, such as an MRI of the heart. But at the St. Barnabas long haul COVID program, your cardiologist will work in tandem with your primary care physician and any other specialists such as pulmonologists to help determine if there is a problem and what the best plan moving forward is to get you feeling better. And with that, I'll turn it back over to Christina.
Just a couple quick questions for you as well from our audience tonight. What are you telling individuals who have had COVID about returning to the gym or back to play?
Sure, this is a question that I get asked a lot. Whether you're a competitive athlete, a weekend warrior, a master athlete, or just starting to get into exercise, if you've had COVID and you're looking to start exercise or to return to play, you should be evaluated by a physician prior to doing so. Now, this doesn't necessarily mean a sports cardiologist, but it can be your family physician, internist, a pediatrician, or a sports medicine doctor. But first and foremost, before starting exercise or getting back to play, you must be asymptomatic. And depending upon how severe the COVID-19 symptoms were, this will guide us on what we need to do next as far as an evaluation and timing of when we can get back to play. And when we're talking about the competitive athlete, if they were asymptomatic or just mildly symptomatic, they likely won't need any further evaluation beyond a history and a physical. But the athlete who's had more moderate or severe symptoms, including if they were hospitalized, my recommendation there is to visit with a sports cardiologist, and additional testing likely will be required. But again, remember, it's important that we individualize each case, and specific recommendations may vary. And whenever the athlete is ready to return to play, there should be a slow, graded return and not just jump right back into it full throttle.
So we've heard the words myocarditis and pericarditis in athletes and COVID. What is it and how does it happen?
So anytime you hear the word or you hear itis at the end of a word in medicine, it generally means inflammation. So pericarditis is inflammation of the pericardium, which is the sac that the heart sits in. Myocarditis is inflammation of the heart muscle. Myocarditis in particular is something we take seriously, as it can lead to heart failure, where the heart's not pumping as strongly as it should be, and it can also lead to dangerous arrhythmias. Now, myocarditis is a known cause of sudden cardiac death in athletes. One of the more common causes of myocarditis are viruses, and different viruses can do this, including the virus that causes COVID-19. We have seen myocarditis related to COVID-19, and there have even been some high-profile athletes with cardiac complications from COVID, which you may have seen in the news, but we've also seen it in our own community. There seems to be a high prevalence of cardiac involvement in patients who are hospitalized with COVID-19, but these tend to be sicker patients to start with. And there is good news when we're talking about athletes. We've been involved in a study with Rutgers and the Big Ten Conference looking at athletes' hearts following COVID-19 illness. And in our study, we've seen a low incidence of myocarditis following COVID-19. And the good news, in addition, is that our experience has been mirrored by other large studies in both collegiate and professional athletes. So while this is certainly good news, we are continuing to monitor COVID in relation to sports and exercise.
Sorry, I was having a little bit of trouble there. If you have a family history of heart disease, does COVID exacerbate those risks? And should you go to a cardiologist to get checked?
So, the short answer is no. Family history won't necessarily increase your risk of COVID, but family history of heart disease does increase your own risk of heart disease. So those are things that shouldn't be ignored. And for those things, you want to see a doctor, visit with your doctor, but not necessarily in relation to COVID.
One last question. This one is a little bit more specific. Someone out there has a 78-year-old father who is now post-COVID and has been experiencing AFib more often, as well as shortness of breath. Is this common? And if so, what suggestions do you have to address this?
We have seen atrial fibrillation, which is an irregular heart rhythm coming from the top chambers of the heart after COVID or during a COVID illness. Now, what we think so far, and again, a lot of our thought is evolving as the pandemic progresses and as we learn more, but we don't think that COVID directly causes atrial fibrillation, but AFib, which is short for atrial fibrillation, is seen commonly during or after any infection, including viral infections such as COVID-19. So we don't think that COVID itself causes the AFib. It's more just the generalized infection. But if someone is experiencing more AFib, more persistent, more frequent, or new AFib, that's certainly something that they should visit their doctor for. And in particular, if they're symptomatic with it, something such as shortness of breath, which may be related to the atrial fibrillation, or may be related to something otherwise cardiac or non-cardiac. So in all those instances, I certainly would recommend a visit with your physician.
Well, thank you for your time tonight, Dr. Lander. It was certainly insightful, and we certainly do appreciate it. Next, I would like to introduce Dr. Schreiber, a licensed psychiatrist who's board certified in adult psychiatry and subspecialty boarded in consultation liaison psychiatry. She works part-time at RWJBarnabas in Florham Park, New Jersey, where she treats outpatients with a variety of mental health issues, including depression, anxiety, OCD, ADHD, and bipolar disorder. Dr. Schreiber also works for the Visiting Nurse Association of Englewood, where she's the Director of Home Care Psychiatry. She also maintains active membership in the American Psychiatric Association, the American Medical Association, and the Academy of Consultation Liaison Psychiatrists. Welcome, Dr. Schreiber.
Thank you so much, Christina, for having me here today. As you've heard from a number of our presenters, there are many manifestations of long COVID syndrome that have to do with the brain, either psychiatric or neurologic. Because COVID, and in particular long COVID syndrome, is really a new illness, it's not really clear in the medical literature who's more likely to get these brain manifestations, how long they're going to last, and there's almost nothing about how to treat them. So the advice that I'm going to give is based on my experience as a psychiatrist over many years treating people with medical illness. So in general, you can divide the central nervous system manifestations, so the brain manifestations of long COVID syndrome, into three broad categories. There are those who've had a direct injury to the brain. They've had a stroke, which means a piece of their brain has died from the COVID syndrome. Or they've had what's called an anoxic or hypoxic brain injury. So the brain has been deprived of oxygen. So those people have findings on a CAT scan or an MRI that can be seen. There are those folks who have this chronic fatigue syndrome-like illness that you've already heard spoken about. And then there are people with long COVID syndrome who have psychiatric manifestations. So in general, you've already heard mentioned this term brain fog, and it looks like from the literature, brain fog in long COVID syndrome is some combination of attentional deficits, short-term memory problems, word finding difficulties, and other kind of non-specific cognitive issues. And it looks like from the research that in those with mild COVID, so those who are outpatients, one study suggested it only occurs in a few percent of patients with long COVID syndrome. But in another study, it was almost 15%. When you think about how to treat this brain fog, again, there's no literature to prove that anything works, but anecdotally, physicians are trying the psychostimulants. So these are things like mixed amphetamine salts or Adderall or methylphenidate, Ritalin, which are medicines we use to treat attention deficit disorder in children and adults. People are also trying modafinil and armodafinil. These are used for excessive daytime sleepiness when people have narcolepsy or sleep apnea. And some colleagues anecdotally have been trying some of the dementia medicines for the brain fog, things like memantine or donepezil. When you think about other symptoms, this was also already mentioned, there's fatigue. And some of this clearly is cardiac or pulmonary, and you've heard that talked about. But some of it is this very severe, again, almost like chronic fatigue syndrome, where it's this post-exertional fatigue that isn't improved with exercise, doesn't get better with rest, and is quite severe. Even just from thinking too hard, people get more tired. And in one study, again, of more kind of minor COVID, so outpatients only, that occurred in almost 15% of patients. But in an Italian study with long COVID syndrome of people who were hospitalized, it occurred in almost 50% of the patients, so quite common. And this type of chronic fatigue syndrome, like fatigue, has also been seen after other viral illnesses, so things like MERS and SARS, so it's a known post-viral phenomenon. In terms of things you can try for this, there are graded exercise programs, whether run by a physical therapist, like you guys are doing in the post-COVID program at Barnabas, or there's kind of self-directed, kind of increasing your exercise slowly. People also may need a graded return to work, so where they start very part-time, only a few days a week, and gradually increase as they feel better. And people may need extra help in the home, things like cleaning help or childcare help. Again, anecdotally, physicians are trying those psychostimulants as well to see if it helps. We've also heard it mentioned insomnia by Dr. Reggie, so very common in long COVID sufferers. And I think the first treatment for that insomnia is really sleep hygiene. So that's things like turning off devices a half an hour before bedtime, making sure you go to bed at the same time with a relaxing bedtime ritual, waking up at the same time every day, shutting all devices off before you go to sleep, not watching TV or doing activities in bed. So bed, as we say, for sleep and sex only. That's it, folks. Okay, limiting caffeine. So you cut your caffeine by 2 o'clock in the afternoon, not smoking or drinking alcohol too late, because that can actually impair sleep architecture. I think the other thing to consider is that people often try over-the-counter sleep medications. And although melatonin might be helpful, we're not sure. I do not recommend things like Tylenol PM, Advil PM, or Unisom, because all those things can worsen the brain fog that long COVID sufferers already experience. And then there are a variety of prescription medications that you can go to your physician if really none of this works. When you think about psychiatric symptoms of COVID, and you've already heard long COVID syndrome, you've already heard this mentioned, anxiety, depression, and a post-traumatic stress disorder like syndrome. In one Chinese study, almost 30% of the patients with long COVID, and these were, I think, sicker patients, had this kind of post-traumatic stress disorder like syndrome. And an Italian study, again, almost a third of the patients with long COVID syndrome had a depression-like illness. So when you think about psychiatric treatments, first you think about good self-care. So things like socialization, hobbies, really making sure that you get enough rest. Exercise can be helpful. So can things like journaling, meditation, or mindfulness exercises. And then some people really may need professional help. So whether that's psychotherapy or psychotropic medications. And I think, you know, as someone who said, it's not gloom and doom. There really are a number of treatments, both behavioral and medication, that can be tried for people suffering from these kind of brain manifestations of long COVID syndrome.
So I have some questions for you as well.
Sure.
What does well-being look like after COVID?
Well, I think especially with people with a lot of fatigue and a lot of brain fog, right? I think you have to figure out what's really important to you in life and spend your time devoted to that. So don't waste your time on social media, for example. If you've got children at home or aging parents you need to care for, or work's important, you got to get back, right? So use your energy for the things that really matter for you, matter to you, and then make sure you build in a lot of rest and a lot of healthy lifestyle routines.
What resources are available to patients and their caregivers?
So there's a lot of support groups out there on social media where people are really anecdotally sharing what works for them, Facebook, other social media platforms. That I think can be really helpful for people. There's post-COVID programs, so like what we're doing at Barnabas, and those are springing up all over the country. And then there's professional help. So sometimes people really may need to go see a psychiatrist or a psychotherapist of some form or another, just to kind of get them over the hump. I mean, as we've heard, this post-COVID syndrome is real and it has a really big impact for some people, and they may need some professional guidance.
And finally, how should people address the fear of the unknown and the anxiety that goes along with that?
Sure. So you know what? We're all anxious right now. And I think people with long COVID syndrome are even more anxious. And I think what you have to do when you're that kind of anxious is realize what you can change and what you can't change. So you need to spend your energy changing what you can, and then you need to really practice acceptance. And as I already said, sometimes acceptance is about mindfulness or meditation. Sometimes it's about support groups. Sometimes it's about talking to loved ones. Sometimes it's about pastoral counseling. Sometimes it's about journaling. But people really need to work on accepting what they can't change and then changing what they can.
Well, thank you, Dr. Schreiber, for joining us tonight. It was actually very insightful, and I'm sure that many of our viewers out there right now, you answered a lot of their questions for them. Before I head into our closing remarks, we did have a question come in for Dr. Trespalacios. So quickly, how long should you wait after testing negative to get the vaccine?
So good question. The latest recommendation based on our current understanding about antibodies and the vaccine is that patients who received treatment with convalescent plasma or antibodies should wait 90 days. And those who tested positive, had mild disease, and did not receive any treatment only need to wait until their doctor recommended isolation period is over.
Okay. So again, I invite all of you to, if you have any closing remarks or anything that you feel like you want to stress upon or just mention before we end our program tonight.
I would just like to say that this is real, that even if you feel like you've been dismissed, there are programs that are trying to help, and that while we don't have all the answers at this time, programs like the one here at RWJBarnabas are diligently working to find answers through research in order to help all of these patients return to their previous state of health.
Dr. Lander?
Sure. COVID and the heart are closely linked in a variety of ways, which we touched upon tonight. If you are feeling symptoms, whether that's acutely or during the recovery phase, please reach out to your physician and COVID specialist. Similarly, I urge any athlete or active individual who's had COVID and is looking to resume activity to speak with your physician prior to doing so we can help guide you back to the best, safest way possible.
Dr. Raju, any closing remarks?
Yeah, I just wanted to say that recovery itself is very variable, and you should really discuss with your physicians about setting realistic goals for yourself and understand that everyone is different in their recovery and no comparisons can be made. But also nobody is alone in their recovery process, and people shouldn't be afraid to reach out if they're experiencing symptoms. I mean, we're all here as a team to help.
Thank you. And last but not least, Dr. Schreiber, any closing remarks?
Sure. Thanks, Christina. I just want to say that, mental health issues are actually a risk factor for COVID, and COVID is a risk factor for mental health symptoms, both in long COVID sufferers and in those who aren't having long COVID syndrome. And I think my message tonight is that there really is a lot of hope, both in terms of things people can do in their own homes and with their own support systems to heal and recover. And then there's lots of professional help that people can get.
Well, thank you very much to our distinguished panelists for all of your insight tonight. I want to also thank those of you at home that are joining us this evening We wish you well, and if you have any questions, please feel free to reach out or look at the listing on the resources available on the event. Have a great night, everybody.